My name is Austin. Most people call me Augustine. That's my actual name, actually. But Austin is more like a short form. And I don't want people to waste their syllables too much. So Austin should be fine. My seminar, before I carry on, Babington, that was a brilliant presentation. Thank you very much. As a matter of fact, I even learned one or two things from there. So, which is why, it is important for us to, make use of whatever opportunity that presents. We can never know everything at the same time. We can always pick one or two things here and there. So I'm going to keep mine very short because I know today is a Sunday. A lot of people have activities to do. People have got to prepare for work tomorrow. Moderator, I'm going to make an appeal. I'm going to be very fast. I'm going to be very theoretical. Perhaps next time we'll create another forum. I'm making a promise to everybody here that the next one we're going to present, still on head and neck, is going to be pathological, review and things like that. But today we're going to deal with a bit of anatomy and technique. Unfortunately, I haven't got a machine here, to demonstrate, but I'll try to demonstrate as much as I can, using my neck. The emphasis, I don't want to bore the participants with too much anatomy. I know when we say head and neck, it's everything head and neck, from where, even if you have a lump here, anywhere, it's head and neck. Of course, we know we have some organs, which includes the thyroid, the salivary glands, and then we have the lymph node. Those are the three key, areas in the head and neck. But for today, because I know most people don't do salivary glands, I think we'll do more of an highlight on the thyroid gland. So the presentation is on head and neck. Like I said, I'm just going to quickly run through the sweeps. Sorry, moderator, I'd like you to share the slide because, like I told you, the technical challenge I have, I cannot share. I don't know if it's possible for you to share the slide from your end. Hello, are you there? Can you hear me?
Yeah, we can hear you. I believe you're working.
Yeah, hello. Yeah. So Marvelous is one that has access to the back end. So he's trying to upload it now.
Okay, that's fine.
Yeah, so just maybe let's give him a few minutes, but you can go ahead, sir, with some other things.
Okay, I'll just go ahead. Just a short background, just like Babington said, or the other moderator said, you see, ultrasound, to a large extent, is something that one has to take resolution into consideration. Because if you don't have a good machine with a good resolution, subtle lesions can be missed, especially when you're scanning areas like thyroid. So it is very important that, when you're scanning thyroid, you use a good resolution machine. I know it's difficult in a part of the world to afford certain machines, but at least there are some that can still do certain things, but definitely not SI 200 or SI 400, because you're gonna miss some pathology. It's very important we keep that in our minds. I know financing, health equipment financing is a problem in our society. But we are hoping that things will get better. So now, some of the common indications, when patient comes for head and neck scan, some of the common indications are, patient can say, oh, doctor, I have a lump here, I don't know what it is, or they may present with hyperthyroidism based on blood tests. I'm talking about the biochemistry now, or hypothyroidism. It could just be a surveillance for cancer. Like those who've got family history of throat cancer and stuff like that. It could be for genetic condition reason. It could be dry mouth. Some people have dry mouth, they have dry eyes, not because they are not drinking water. That was a joke anyway. Now, the reason why they have that is because something is blocking the salivary gland. So when things like that happen, well, the doctor refers the patients to you, who is a specialist, and they expect you to give them, an answer to what's causing that patient's problem. Can you go down to the next slide, please? Yeah, just keep going, please. Keep going. Keep going to where you have technique 7. Yeah, that's it. So for the head and neck ultrasound, you see there are different regions of the neck where you do the sweeps. And these are from level 1 to level 7. And each of those levels have their lymph nodes. And those lymph nodes have a specific drainage to a particular area. For instance, I'll just give you an instance. If I'm scanning and then a patient has a lymph node or a swollen lymph gland under the chin, the first question I'll ask that patient is, have you got a dental issue or have you got a dental infection? Because level 1 lymph nodes drain everything around the, like the dental area, So it is important for you to know the reason. Yeah, it is important for you to know the reason for certain reactions from certain lymph nodes. That can guide you into knowing exactly what that case might be presenting. Because you could see a patient, swollen lymph node, you look at the thyroid is normal, you look at the salivary glands is normal. It doesn't mean that something is normal. There must be something going on somewhere. That's where, biochemistry comes in. If the markers are raised, then that patient will definitely need to have a CT scan, because there could be very, subtle lesions in the tongue base. So lymph nodes are very, critical markers that can point to, certain significant pathologies. Although people could have swollen lymph nodes as a reactive process, not necessarily cancer. It could be a reactive process. For some people, it could be lymphoma. So those are all some of the things to put into consideration. I'm not saying that at the end of this lesson you're going to go and become a head and neck. No, I'm just giving you an overview so that you have an understanding of, what this entails. I guess these lectures will be ongoing, so we can always treat areas based on popular demand. So the sweep 1, I don't know if you can see my chin. I don't know if the lighting is okay. When you say sweep 1, now when a patient comes for thyroid scan, I want to advocate this. Try to look at the rest of the neck. Don't just do the thyroid. And please, I just need to say this because I think most of our people do this a lot. We're not interested in the measurement of the thyroid. We are more interested in the appearance of the thyroid. If thyroid is enlarged, something is making it to be enlarged. And sometimes when thyroid is enlarged, it's subjective. You just see that, no, this one is enlarged. Yeah? It's either there are nodules in the thyroid or there's an inflammatory process going on in the thyroid. So you're saying thyroid measures 36 cm by, it doesn't help the clinician. They want to know, is it enlarged or not? And if it's enlarged, what can you see sonographically that is causing it to be enlarged? If you're not seeing nodules, then your duty is to say, okay, the thyroid gland appears enlarged. In that case, if you want to put measurement, fine. If you don't want to put measurement, it's up to you. But you've given them all they want to know, is it enlarged or not? And did you see what's causing the enlargement? If you don't see anything causing it sonographically, then that's when they now go for biochemistry. So don't focus more. Your focus should be more on the appearance, the echo texture, because it is the echo texture that tells a lot about what's happening to the thyroid gland. So I go back to the sweeps. So sweep 1 quickly. From here, this region, there are 2 muscles here, which are the anterior belly of the digastric. You just sweep it down this way. I don't know if you can see me, or you look at the diagram. You sweep this way, sweep down. What you're looking out for is what? Lymph nodes. Because you don't have it, there are no organs here. You're just looking at the lymph node. So if you look at the presentation there, the anatomic structures under consideration is level 1A lymph node, which is the one at the submental region. There sits, just adjacent to the anterior belly of the digastric muscles. Then around that same level 1, you also see the hyoglossus, the genoglossus. Those are all tongue muscles. And then the sublingual space, the palatine tonsil, and the Wharton duct. That's for sweep 1. For sweep 2, okay, before I go into that, more common variant. Now, the things you will see in that region, again, like the pathologies that you see around there, which you have to keep in mind, like mucous retention cysts, sebaceous cysts, very common. Sebaceous cysts are very, very common. As a matter of fact, they are one of the most common, lumps on the head and neck region. But you have to bear in mind, they are always subcutaneous. And if you're using a good resolution machine, you always see a punctum. If you see a punctum, it tells you that this is classical sebaceous cyst. The other name for sebaceous cyst is what's it again? Epididymoid cyst. Epididymoid. So it's classical. You just see it. Usually they don't have internal flow on color Doppler, which brings me again to this point that you cannot do head and neck ultrasound without color Doppler. You cannot do thyroid scan without color Doppler. Because things like thyroiditis, it is only Doppler that can tell you that this is classical thyroiditis, not just the ecotextural appearance. Because with thyroiditis, you see inflammation, you see hypervascularity or moderate increase in vascularity. So it is very important that you take note of those things. Or when you scan and you feel, I'm not too sure that this is thyroiditis, it's up to you. You can state it on the report that the machine you're using is not a color Doppler, so it's not it's an inconclusive examination. That's up to you. But I know in Nigeria, if you do that, you will not get referrals. They'll go to other places, isn't it? So, mucous retention, sebaceous cysts, oropharyngeal primary lesions. Now, why I need to point out something here. There was a day I was scanning. That patient didn't come for, anything that has to do with the tongue. The patient came because there was a swelling at the back. And that swelling at the back was a lipoma. But because I'm used to doing the sweeping, because it is important to do those sweeps, in the process, I found out that there was a tongue lesion. And that tongue lesion, at the end of the day, when the patient had a CT scan, it was really an aggressive sort of lesion. So if I had focused on the lump at the back, who knows, maybe in the next 6 months that patient will be gone because nothing was picked up. So you're not doing this because you're doing this as a way of helping. Nobody's going to, even if I didn't do that, nobody's going to come back and say, why didn't you scan? Because the request was the lump on the back, at the back of the neck, yeah? But it is because I know that it's important for us to just do like an MOT. MOT is like just check to make sure that things are within normal limits. It's just a way, an additional service to the patient. By so doing, we picked up pathologies, very serious pathologies. So it is very important to also have that in mind. Sweep 2 is the submandibular space. So from the mandible to the level of the hyoid. So the hyoid bone is around this area here. So if you look at the mandible, yeah, then if you come down like 3 centimeters downwards, just close to your anterior neck, before the cricot cartilage, there are tiny bones there. Those are the hyoid bones. So you're sweeping this way. Bear in mind, you swept like this for level 1, and then you're sweeping this way. The sweeps, you're looking for lymph nodes. This one you have to look for. You have to look for those lymph nodes. Make sure that the echo texture is firm, that they've got a fatty hilum. If you see a lymph node that is hypoechoic without the fatty hilum, and the shape is rounded, like it's got a rounded configuration, such lymph node, it may not be cancer, but I wouldn't let such lymph node go. I would rather bring those patients back in 2 months, because in 2 months there will be a lot of changes. Either it will regress or it will increase, and if it increases, then we're going to definitely do a biopsy on that lymph node. So let's carry on. Like I said, just bear with me. I know it might be a bit confusing, but I'm just touching these areas. I'm going to go down to the thyroid, which is what I want to focus on today. The other ones you can read them later on. And if you need any answer or anything, you can always get to me on that. So normal variants, there are possible normal variants of pathologies, like metastatic lymph nodes, all those things we've mentioned in the past. Sweep 3 is a parotid space, which is from the external auditory meatus to the oral commissures to the mandible. So more like here, you're going this way, and that's the area of the parotid gland. The parotid gland is here. So you sweep all the way down. It's best understood if there's a patient and then we are doing demonstration. It's best understood. But for now, just bear with me the way I'm kind of demonstrating. Maybe in future, we're going to try to see if we can arrange one where we do a live demonstration. But you just need to have an idea of the sweeps. And then the other one is sweep 4, which is a level 3 and level 4 nodal group. Now, level 3 is at the level of the hyoid laterally. Remember, the hyoid bone is close to the midline. But all the lymph nodes lateral to that area, that's level 3. Now, level 2, you've got the submandibular gland. As the name implies, submandibular, below the mandible. So all the lymph nodes from the submandibular gland laterally is level 2. Then level 4, you've got the thyroid. Anything lateral to the thyroid, all the lymph nodes lateral to the thyroid gland are level 4. Then level 5, you've got the sternocleidomastoid muscle, which is more like the midline of the neck. Yeah, just below just posterior to the, slightly posterior to the ear, and then sternocleidomastoid muscle, that's it there. One of the biggest muscles in the neck. So all the lymph nodes around it, all the way down to the shoulder, that's level 5. So that's how they class it. So if you're writing a report to an ENT surgeon, they want you to, like if you say there's a lymphadenopathy in the neck, they will really appreciate you if you mention the level, because that guides them to know which organ to focus. So that's how it is important for you to class this lymph nodes. And then level 6 is inferior to the thyroid, just close to the collarbone. Anything you see around there is level 6. Now level 6, you don't normally see them, because they are very tiny lymph nodes. The only time you see them when they are prominent is if there's thyroiditis. As a matter of fact, if you see swollen level 6 lymph nodes, hypoechoic, just know that patient that there's thyroiditis. Even if the thyroid looks normal, it's ongoing. You know, so hello.
Yeah.
Oh, okay, I thought someone was asking something. So that's sweep 4. Sweep 5, from the level of the subclavian vessels to anterior border of the trapezius, which is what I've said earlier. And then the sweep 7 is the thyroid or central neck. Now, sometimes you see people with swelling here at the sternal angle. That swelling is not necessarily thyroid nodules. You see the sternoclavicular joint sometimes does have degeneration. For those of you who do MSK, I'm sure you know what I'm talking about. Yeah, and when it's degenerated, it appears so swollen that you think, oh, there's a lump there. It's also very important to just look through, see the joint itself. If there's degeneration, you see that there will be a cortical irregularity, and you put your flow there. If there's no flow, that is classical for, you know, degeneration. But if there's flow, you might be looking at synovitis. You know, so those are also things to consider when doing head and neck ultrasound. Now, coming to reporting thyroid gland. Can we move down to reporting thyroid gland, please? Because I don't want to spend more than 10 minutes. Like I said, reporting thyroid gland. Yeah. So in reporting thyroid gland, which is one of the most common examinations of the neck, you have to include a brief of clinical history and a clinical observation or conversation during the scan. Now, I say this because sometimes, I don't know about Nigerian doctors, but most GPs in the UK, they give you very little clinical information. They can just say neck swelling, query thyroid, query whatever. So it is now left for you as an advanced practitioner to flag that patient. You ask them, because there are certain things you will find out there that will help you in making a diagnosis. You know, so it is very important that you have a conversation with your patient, and this is why you also need to be clinically versed to know how to correlate what the patient has told you, what you're seeing, to the findings. So it is, that communication is very important. Don't just depend on what a doctor or a query neck swelling. Sometimes there's no neck swelling there. They just want to, you know, send the patient away by requesting for that scan. These are things we've seen, you know, and you need to have differentials. You need to know differentials. As a matter of fact, if you're practicing ultrasound, differentials should be something you should yearn to know in your fingertips, because what we may see and you think this is it may not be, you know, so you need to have that, you know, differentials diagnosis in your head as you're scanning. And then comment if appearances are atypical or not in keeping with clinical questions, and offer explanations where possible. Sometimes you can advise the doctor and say, you know what, this patient might need this other examination. But I must mention that ultrasound is the best modality for thyroid, because CT scan, from experience, we see that CT scan and MRI, they might see a nodule, but they can't class it. They just know there's a nodule there, but they can't class it if it's a malignant or if it's a, you know, benign nodule. Also, even for PET CT, they can pick up a nodule that it might appear hot, like a hot nodule, but they still come down to ultrasound to classify. So ultrasound classification is actually the gold standard, which is why it is very important to know, you know, how to report and classify those nodules. Now, the size and echo texture. By the size, I'm not saying you should put the size and say 3 centimeter by this, that. You can do it, but it's not. I don't think it's gonna add anything to the management of the patient. If it's enlarged, it's enlarged. If it's not enlarged, it's not enlarged. Just like the liver. Most of us in our trust, we don't even, if it's enlarged, we say, okay, it's greater than 16 centimeters. We just write it there. We don't necessarily say it's 200 centimeters or 300 centimeters. We just say it's greater than 160 centimeters. That shows that it's enlarged. And we only do that when it's enlarged. When it's not enlarged, you don't need to say the liver is not enlarged. You can just say the liver is normal size. So same thing with the thyroid. If you look at it from experience, you know that this thyroid is not enlarged or this thyroid is enlarged. But I'm not saying you don't have to write the size, but it's not. It's not really important. Focus more, because sometimes that measurement makes you to lose focus on the diagnosis, not just in thyroid, even in other areas. Some people, when they want to scan liver, they just go straight to, they just want to take measurement. Meanwhile, what is more important there is to sweep through. You're looking for things that are not there. That's what we are. Sonographer, we look for things. Let us look for things that are not there. If we don't see them, we know that we didn't, but not to focus on a particular thing and then you lose out on those subtle things. So size and echo texture of the thyroid, homogeneous. It should be homogeneous. Sometimes it's hypoechoic. I believe I'm speaking to people who know ultrasound terms. I don't know. If you don't know, you can call my attention, during the question session. If the thyroid gland is hypoechoic, there are two things. One of the things is 90% thyroiditis. Now, the hypoechoic I'm talking about here is diffuse, like diffuse hypoechoic, not just focal. Anything focal hypoechoic is suspicious until proven otherwise. On the thyroid, as a matter of fact, thyroid we fear hypoechoic, anything hypoechoic. I'm going to give you the classification later, but I'm just giving you a rundown. So anything that is between hypoechoic and hyperechoic that is not clear, you either recall and do rescan, or if you're not too happy, you do a biopsy. But the thyroid gland should be homogeneous. It shouldn't be hypoechoic. It should be like normal, like when you see testes. When the parenchyma texture is just homogeneous. And then when you have focal hypoechoic areas in the testes, they are concerning. Same thing applies to the thyroid gland. So for thyroglossal cysts, they are also very common in the neck. They are linked. There could be anywhere. There could be below the thyroid. There could be above the thyroid, but it's one common cyst in the neck. So measure where possible and do fine needle aspiration as indicated. On the guidelines, is from level 3 or U3 that we do FNA. Now the classification. Okay, I don't know if you can zoom it from there. I don't know if they can see. Yeah, so move it to U1. Let's talk about U1. So U1 is just a simple cyst. Like when you see an anechoic cyst without anything, just anechoic, thin-walled, like a normal simple cyst. That's U1. Thank you for doing that. Then U2, you might see a cyst with either internal echoes or hyperechoic crystals or whatever it is. So long it is a cyst, it is a simple cyst that contains some things, that's definitely a U2 cyst or U2 nodule. Anything cyst that contains a solid component, but I need to mention here, there's a caveat here. solid component that is not vascularized, and solid component that is not hypoechoic than the surrounding thyroid tissue. Anything that is hypoechoic to the normal surrounding thyroid tissue will ring an alarm. U3 is when you have, for instance, you're meant to see a nodule that is meant to be spongiform, or a nodule that is cystic, but you're having a mix of a spongiform and a cystic nodule with some hypoechoic areas. U3 just means equivocal, like in between. You're not sure. Any nodule you're not sure of, we class it under U3, which means you're saying it is neither benign nor malignant, so you're not sure, equivocal. So such nodules, depending on other history or other things, other clinical relations, such nodules, we will put it up for either we say, okay, follow-up scan in 2 months, or we do a biopsy. We often opt for biopsy, unless if the patient is needle phobia, then we can give them some time to think about it. That way we can do an interval assessment to see if there's any change. And then U4, when you see a nodule that is hypoechoic to the surrounding thyroid, that is a suspicious nodule, U4. Hypoechoic is the word. As a matter of fact, if you're scanning, if you see hypoechoic nodule, it should raise some concerns until proven otherwise. Now, the difference between U4 and U5 is that U5 will be hypoechoic, and then it will now have microcalcifications. As a matter of fact, that one you can even say, oh, this is definitely a, either a papillary or whatever, until proven otherwise. But bear in mind that some nodules also come up with what? Metastasis. So when you see a nodule and then you're seeing level 4, in this case it's level 4 because level 4 lymph nodes are the ones that drain the thyroid. So if you see a nodule, let's say U4 or even U3, from U3, if you see a nodule that is, coexisting with an enlarged lymph node, level 4 lymph nodes, that nodule has to be aspirated. Have to be biopsied, because that's really, as a matter of fact, that's almost like 80% malignancy. So the biopsy is what will now tell exactly what the cytology is. And then for some cancers that are not aggressive, they might do partial thyroidectomy. But for some, they just do complete thyroidectomy. So hypoechoic is a word. Anything that is any nodule that is hypoechoic to, remember I'm saying nodule. Nodule, of course, you know how a nodule is. Most nodules are rounded. They've got a rounded configuration. They could be taller than wide and all that. But I'm not saying like a segmental hypoechoic area. If there's a segmental hypoechoic area or a geographic hypoechoic area, that might be thyroiditis. But anything that looks like, when you see a nodule, then hypoechoic is really concerning. So those are like the basic classifications, and those are the things that decides that kind of brings up our decision about proceeding with an FNA or not. So just like I said earlier, echo texture, size, and comparison to ipsilateral side is very significant. presence and absence of calculus with size and position as applicable. But I need to mention something here. Calcifications are very common in thyroid. Yeah, they are very common in thyroid. When we worry about classification, about classification is when you have a hypoechoic nodule with calcifications in them, we worry about them. But when you have a normal thyroid gland with some calcifications, those ones we call them cause calcifications. They are most likely, as a matter of fact, they are most likely benign, just like when you have calcifications everywhere. But the ones we worry about are those microcalcifications within a hypoechoic nodule. So those are two different things. So don't go and scan a patient tomorrow with calcification and say, oh, this is definitely U5. No, it doesn't work that way. You can just describe that there are cause calcifications. Some can just, like in the case of multinodular goiter or multinodular thyroid, that's a new name, please. It's no longer multinodular goiter. It's multinodular thyroid. So when you have those situations, you often get calcifications in some of the nodules. So you can only describe them as, maybe cause calcifications. The take home I want us to take home tonight is that thyroid nodules are very common. As a matter of fact, it's more common in women. If you have 5 women here, one definitely has some form of nodule. It's very common in women. So you have to keep that in mind too. Most likely related to hormonal, issues. So multinodular thyroid is a common situation. You have, sometimes we find them incidentally. Sometimes patients don't even present with any clinical symptom. They came for other scans, but in the process of sweeping through the neck, we see them, you report. So long it is U2 and below, it's just a follow-up. They don't have to go and take the thyroid out unless if it becomes, if it's kind of compressing on the neck and they can't swallow anymore, they can't breathe, then in that case the ENT surgeon would decide if they have to take them out or not. And then quickly, I know I'm out of time, major salivary glands are something we also need to have in mind. You don't have to just go and start doing them. You just, when you have it in mind, you start practicing, because sometimes you see them, but because you don't know how to get to them or what to say, people just ignore them. But you just have to keep it in mind that it's also very important, because by so doing, we've also picked up incidental lesions on the salivary glands. But the good thing with salivary glands is that the lesions in salivary glands are mostly benign. About maybe 80% are always benign. Either they are Wharton's tumors or pleomorphic adenoma. So it's something, moderator, I think we'll need to deal with this particular topic next time. But let's just know that salivary glands, we have the submandibular gland there, we have the parotid gland there, and then the sublingual just beside the tongue, And then lymph node. Let me just talk quickly about lymph nodes. Lymph nodes are supposed to have like a bean shape. When you see a bean shape, oval, with a central echogenic area, which is the fatty hilum. Move downward, please, which is the fatty hilum. And normal lymph nodes should be what? Less than 10 millimeters. This is neck for ultrasound of the neck. Normal lymph nodes are usually less than 10 millimeters. Now, if they are 10 millimeters and above, what you need to consider, or what you need to take cognizant of, is how is the shape. Any lymph node that is round is concerning. So if a lymph node should maintain an oval shape, a lymph node should have an echogenic fatty hilum. However, a lymph node could have an oval shape without the echogenic fatty hilum, but in that case, it could be reactive. Because when a lymph node is reactive, it loses that echogenic fatty hilum. So you just see a hypoechoic lymph node. So long it is oval and the measurement is, let's say 10 mm and below, it could be reactive. But for me, what I would do is, if that patient hasn't got any upper respiratory tract infection or something like that, I will rescan that patient in about 8 weeks just to make sure that it hasn't grown. If it's grown by maybe 1 millimeter, I might give another 8 weeks to see. Then if it's stable or it's gone down, then that patient will be discharged. Most likely that's a reactive. But for malignant lymph node, you see that they will begin to lose that oval shape and they begin to become roundish. And for the ones that are necrotic, you won't even see blood flow, internal flow in them. So this is, I'm sure they are very common here because of TB. Sometimes you see them more in level 4 too. Level 4 and supraclavicular lymph nodes. Any lymph node you see just slightly above this clavicle, supraclavicular lymph node, that's what they are called. They are mostly, the first thing we think of is TB. Like in the UK, we ask them, have you been to, if he's an Asian, we know that this person has either come from Asia or went on a visit, or if he's Nigerian as well, the same thing. But for a white person who hasn't traveled, the first thing that comes to our mind is SCC, sickle cell carcinoma, maybe metastasis. So it's very important to also know how the configuration of a lymph node is. So in reporting lymph node, sometimes a patient might come with a swelling maybe anywhere, and you scan and you know that's a lymph node. So in order to put that patient's or the doctor's mind at rest, you just describe the lymph node as this is measuring its short axis dimension, anterior posterior diameter, the maximum diameter. That's where you measure. So you can just describe and say, oh, this and that lymph node, measuring that in maximum short axis dimension, not significant by morphology or size classification. Morphology means you're telling them that it's still maintaining the oval shape and the size is within the 10 millimeters limit. However, you need to also know that there are some lymph nodes called jugulodigastric lymph nodes, which are level 2 lymph nodes. They are the largest lymph nodes in the neck. Just they are posterior to the submandibular gland there, just around the angle of the mandible. Those are the largest lymph nodes in the neck, level 2. Those ones normally they can measure even up to 12 millimeters because they are large lymph node. But so long you're seeing the echogenic fatty hilum and the shape is not rounded, then you're good to go. So that's that for lymph nodes. And for some lymph nodes, we don't FNA, because if lymph nodes are necrotic, even if you put a needle in there, you're not going to get any good tissue because they are all necrosed. So in that case, we do a core biopsy, which is taking a chunk of tissue, a bigger needle goes in there, pull it out, not the lymph node, you just take out some tissue chunk, send it to cytology, who will now decide what it is or the cause. So if you look at figure 1A, it's more like a summary of the levels of the neck. So everything, I'm going to summarize again, I've said it earlier, anything around the submental region is level 1A. Then lateral to that submental region before the mandible is 1B. And 1B is very close to the submandibular gland. That's the medial aspect of the submandibular gland. That's where you see. So any lymph node around that region is 1B. And then 2, you can see there, just almost at the angle of the mandible. So any lymph node you see around there is level 2A. Then if you go laterally, you can see where there's 2B there. 2B means it's that same level, but it's going a bit laterally. So that's 2B. If you see anything again, if you move beyond that 2B, you're heading to level 5. So level 5 is where the sternocleidomastoid muscles are located. Therefore, level 3, you come like 2 centimeters below the angle of the mandible, where you see the hyoid bone. So once you see the hyoid bone, lateral to it is level 3. Then you come an inch down to the thyroid. That's level 4. Any lymph node you see lateral to it is level 4. Now, when you give these levels in your reports, whoever is referring, I don't know if they will know that this person knows what he or she is doing, that you're guiding them. It's a clinical report. You don't just say there's a lymph node in the right side of the neck. You have not helped them. You've confused them. And you don't want that patient to come back again and pay for another scan. So it is very, very important. Now, this overview I'm giving so that we will do like I'm sure the moderators know what to do. We'll pick a day and focus on a particular thing and say, okay, this is what we're going to do. Then we'll bring diagrams, we'll bring cases. So I'm just exposing us to some of the things that are done. So in order not to waste your time, I think I will end at this point. Thank you very much for listening.